Hi all, I'm Malavika, and in this video, I'll be explaining about atherosclerosis. Atherosclerosis is a progressive disease of the tunica intima layer of blood vessels involving large and medium-sized elastic and muscular arteries. It is characterized by the presence of atheromas, which are focal or localized lipid-rich intimal lesions. CAD or coronary artery disease and stroke are important manifestations of atherosclerosis. Risk factors for atherosclerosis can be divided into three types: modifiable, non-modifiable, and additional risk factors. Modifiable risk factors: the first one is hyperlipidemia, in which there is increase in serum cholesterol or hypercholesterolemia, increase in LDL, which is bad cholesterol, and decrease in HDL or good cholesterol. The next one is hypertension. Then we have cigarette smoking. And finally, diabetes mellitus. Diabetes mellitus is associated with hypercholesterolemia. Non-modifiable or constitutional risk factors include genetics. Example is familial hypercholesterolemia, which is an inherited disorder. Then family history, age. Atherosclerosis is more common in people who have crossed middle age. And gender. Premenopausal women have lower risk of atherosclerosis due to the protective role of estrogen. This protective effect disappears in women after menopause. Additional risk factors include inflammation, increase in CRP or C-reactive protein levels, hyperhomocystinemia, metabolic syndrome, increase in lipoprotein A, increase in procoagulant levels, inadequate physical activity, clonal hematopoiesis, stress, obesity, and alcohol consumption. For the additional risk factors, just remember the letters A, H, O, S, C, and I, where A stands for alcohol consumption, H stands for hyperhomocystinemia, O stands for obesity, S stands for stressful lifestyle and syndrome, as in metabolic syndrome, C stands for clonal hematopoiesis, I stands for increase in lipoprotein A and procoagulant levels, inflammation, and inadequate physical activity. Coming to the pathogenesis, there are several theories explaining the pathogenesis of atherosclerosis, out of which the most important one is the response to injury hypothesis. According to this theory, atherosclerosis is a phenomenon which occurs in response to chronic endothelial injury. When there is chronic endothelial damage due to hyperlipidemia, hypertension, smoking, toxins, or any other factor, monocytes will undergo adhesion and they will migrate into the tunica intima. Once they reach the tunica intima, they will transform into macrophages. The vascular permeability will be increased and there will be platelet adhesion and thrombosis. LDL will move into the tunica intima. Macrophages will become activated and smooth muscle cells will migrate from the tunica media into the tunica intima as shown in the figure. Macrophages and smooth muscle cells will engulf lipids and lead to the formation of foam cells. Foam cells are responsible for the production of fatty streak, which is the earliest lesion seen in atherosclerosis. Some of the foam cells will undergo apoptosis and release the engulfed lipoproteins and oxidized LDL. Oxidized LDL is harmful. It is cytotoxic to the endothelial cells. It activates macrophages, which produce cytokines, chemokines, and reactive oxygen species, which worsen the condition. There will be proliferation of smooth muscle cells, deposition of collagen and other ECM components, and extracellular accumulation of lipids. Proliferation of smooth muscles is mediated by platelet-derived growth factor or PDGF and fibroblast growth factor or FGF. Collagen synthesis is regulated by transforming growth factor beta and interferon gamma. This is how a fibrofatty atheroma with a lipid core and fibrous cap is formed. Coming to the morphology of atherosclerosis. Fatty streaks are the earliest lesions seen in atherosclerosis. Gross appearance: they are multiple small flat yellow lesions in the tunica intima. They may coalesce to form long streaks, about 1 centimeter in length. They may be raised mildly above the intima, but they usually do not restrict blood flow. Microscopy: Fatty streaks consist of lipid-filled foamy macrophages in the intima. Atherosclerotic plaque or atheroma. It is most commonly seen in the abdominal aorta, followed by coronary arteries, popliteal arteries, internal carotid arteries, and vessels of circle of Willis. It is white to pale yellow in color and red-brown when there is a superimposed thrombus. Atheroma protrudes into the vessel lumen. It is 0.3 to 1.5 cm in diameter with irregular shape and well-defined borders. It consists of a soft yellow grumous lipid core and a white fibrous cap. Microscopy. It consists of three components: cells, including smooth muscle cells, macrophages, and T lymphocytes; extracellular matrix components like collagen, elastic fibers, and proteoglycans, and lipids. There are three regions for an atheroma: a fibrous cap, which consists of smooth muscles and collagen; a central necrotic core containing lipids, necrotic debris, and foam cells; and a shoulder, which is the peripheral region, which mainly consists of cells, namely smooth muscle cells, macrophages, and T lymphocytes. Neovascularization can also be seen mainly at the periphery. Complications of atherosclerosis include rupture, ulceration, erosion, and fissuring of the surface of the plaque, thrombosis, atheroembolism, hemorrhage into the plaque, aneurysm, and calcification. Finally, we have the clinical consequences: MI or myocardial infarction, stroke, dry gangrene of foot, and aneurysm. So that's all about atherosclerosis. Thank you for watching.